start talking about renal failure. Okay, this might be a very, very refreshing to you because it's a very easy concept. So we're going to be talking about this. Remember that the kidney main function is, first of all, formation of the urine. Second and most important is wasting byproducts of the metabolism, right? Like urea is one of the main waste byproducts. Regulates body water volume. The kidney, if you recall, in the distal tubule, it has the aldosterone, right? And the aldosterone, remember, the main function is to reabsorption of water, okay? So whenever a patient has renal insufficiency or end-stage renal failure, depending on the stage and the damage of the kidney parenchyma, then patients would have volume overload, right? Because the kidney is in charge of volume control. In addition, regulation of blood pressure. If you also recall, the kidney in the justagaleural apparatus, there's a release of renin. Going back to pathophysiology, remember that since the kidney is in charge of regulating volume and pressure, whenever there's a change in volume or pressure, there is activation of the catecholamines, which is your norepinephrine, epinephrine, etc., right? And that's to be able to produce vasoconstriction and regulate blood pressure, right? So if that doesn't improve the volume status of the tissue, in this case the kidney, then the kidney is activating the justagaleural cells to release renin, right? Renin basically will activate, believe it or not, angiotensin 1 is not only released at the level of the kidney, but it will send the feedback to the liver to also release angiotensin. And angiotensin is also released in the lung. And you will realize this when we talk in the lung about sarcoidosis, okay? So it will send signals to organs, either central like the kidney or distal, to be able to release angiotensin 1 to produce vasoconstriction, right? If that doesn't improve, then remember that in the prerenal arteriole, we have an enzyme which is called angiotensin converted enzyme that converts angiotensin 1 to angiotensin 2 to produce a more potent vasoconstriction to regulate volume and pressure, right? If that doesn't improve the volume and pressure, then what happens is that there's activation of the adrenal cortex and sending a feedback to the aquaporins in the distal renal tubule to release aldosterone. And aldosterone will regulate reabsorption of sorbitol water and excretion of potassium, right? And then, of course, vasopressin that is also released, right? Which is ADH. So in addition to that, the kidney is in charge of regulating acid-base balance. First of all, urea is an acid, being a wasting byproduct of the metabolism. So accumulation of urea not only is toxic for the tissue, including the brain, and patients become encephalopathic when they have renal failure, but also increases the amount of hydrogen ions, producing acidosis. In addition to that, at the level of the proximal tubule of the kidney, there is a major reabsorption of bicarbonate, which also participates in the regulation of acid-base balance. On top of that, you know that alterations of potassium mediates acid-base imbalance, right? So since aldosterone not only is present in the renal cortex, but it's also present in the distal tubule of the kidney, if there's any major renal insufficiency or end-stage renal failure, aldosterone will not be able to excrete potassium, and there's an accumulation of potassium. Therefore, hypokalemia will produce metabolic acidosis, okay? So in addition to that, you also remember that the kidney is in collaboration with the hematopoietic system because the kidney will produce erythropoietin, right? It's not one of the major factors in the bone marrow to produce red blood cells, but it's a co-adjuvant. So patients that have renal failure, they tend to have lack or deficiency of erythropoietin, producing a normal cytic, normal chronic anemia, right? And electrolyte imbalances, as I said, if you have renal failure, look at the amount of electrolytes that can be reabsorbed at the level of the kidney in the proximal proximal, mostly sodium bicarbonate and chloride. And as you go distal, there's more waste of water and less electrolytes. So the more proximal you go, the more excretion and wasting of electrolytes. So patients tend to have loss of bicarbonate and therefore metabolic acidosis, hyponatremia, hypokalemia, versus if you compare this to the convolutubule, patients would have more excretion of water and hypovolemia versus loss of potassium and sodium, etc. Okay? In addition to that, let's combine the kidney with the parathyroid gland. If you recall, you would understand this, why patients with end-stage renal disease, they have problems with calcium and phosphate. Because remember that the parathyroid gland will release parathyroid hormone whenever there is hypocalcemia being present in plasma, right? So PTH acts directly at three main organs: your bones, your GI, and your kidneys. And when there's the presence of hypocalcemia, normally, right, the PTH is able to reabsorb calcium at the level of the GI tract, at the level of the kidney, and extracting the calcium from the bone and put it into plasma. So that's one of the major problems that patients with end-stage renal disease have, that they tend to have osteoporosis because of extraction of calcium and being placed into the plasma, okay? And there's an inverse relationship with the phosphate. So you would see that these patients tend to have hyperphosphatemia and hypocalcemia when there's renal failure, okay? Now, how does the urine is formed? Remember that kidney filtration or tissue perfusion at the level of the kidney comes from the cardiac output. 20% of the cardiac output goes to the kidney to perfuse the tissue, okay? And that amount of blood flow that enters the pre-renal arteriole will produce what's called glomerular filtration rate, okay? When the glomerular filtration rate is affected, there's tissue hypoxia into the nephron, producing acute renal failure, right? If you recall from pathophysiology as well, we have in the pre-renal arteriole that I emphasized when we went through cardiac, the angiotensin converted enzyme, and in the post-renal arteriole, you have the prostaglandin, right? Remember that whenever there is low volume coming into the nephron, we need the angiotensin converted enzyme to be able to convert angiotensin 1 to 2 and produce what's called autoregulatory response. And the prostaglandin in the post-renal arteriole will dilate the post-renal capillary to avoid high pressure at the level of the nephron, right? Just keep that in mind, and then we'll continue. So, this is basically what I just explained, okay? So we have what's called autoregulatory response, which is no more than the afferent arteriole is regulated by angiotensin converted enzyme, and the post-renal capillary is regulated by prostaglandin. Vasoconstriction in one end to be able to increase perfusion in the nephron, but to avoid damage with high pressure, the prostaglandin will dilate and the volume will continue into the tubules, okay? So the reabsorption of electrolytes and volume will not be affected, okay? So as I stated, you need a good volume going into the kidneys, coming from the heart. So anything that affects the cardiac output will affect glomerular filtration rate, okay? So this is no more than, it varies between men and women. Why? Because not only the glomerular filtration rate, I mean, remember that in pharmacology we talked about volume of distribution, right? Which I'm not gonna test you on that. But just to have in mind why we have a difference. First of all, muscle mass, right? The man has more muscle mass than the women, right? We have more fat, more water. So therefore, our glomerular filtration rate is less, the same as creatinine compared to the guys, okay? And also in the elderly population, the less volume mass they have, you would see that some patients with renal failure, they do not have any changes in creatinine clearance because of the amount of muscle mass that they have. even more, they are malnourished when they're cachectic, because it depends on the muscle, okay? So again, what factors affect glomerular filtration rate? Hydrostatic pressure. Again, the higher the blood pressure, even though you might think, well, normally what actually affects primarily glomerular filtration rate is hypovolemia, but even though autoregulatory response depends on the vasoconstrictive effect of the catecholamines, the renin, angiotensin 1 and 2, remember that it's a vicious cycle or negative feedback if you have a severe hypertensive urgency or emergency. So the higher the blood pressure, the higher the pressure in the capillaries, and the more the capillaries are affected, producing tissue hypoxia and therefore fibrosis at the end. Okay? So you need to have a steady state or balance.
That's the one that has to do with the proteins and drawing in and out of the vessels, right? Like you have
the hydrostatic pressure.
And
Yeah, the hydrostatic pressure, again, if you recall in pathophysiology,
it's like if you have low posturing, it's gonna go like outside.
that's
of
why
the
we
body.
need more time.
Where you going then?
Y ahora.
Oh, no, I think, isn't it behind here?
Nope.
All right.
You can draw with the mouse.
Of course we have a teacher.
Yeah, but is that right? Like if you have like the proteins, like if you have high proteins, it's gonna be the oncotic pressure pulling inside the vascular, right? That'll be the.
You should have that. Okay, there are two forces that mediate this steady state of the balance of volume, right, inside of the capillary. Remember that? Blood pressure is no more than the pressure that the blood exerts in the wall of the capillary, right? Okay, that's blood pressure. Now what happens is that the higher the pressure that exerts the blood volume in the capillary, and that produces a leakage. It's a physiological leakage, okay, of volume to the outside, which is the interstitium. That is called hydrostatic pressure. Okay? Now, but if the volume stays outside in the interstitium, that produces edema, right? So we have to bring it back in to be able to be in balance. And to be able to bring it back in, there's another pressure, which is called oncotic pressure, or colloidal osmotic pressure, which is mediated by proteins, right? Now, if these two factors are affected, again, what is hydrostatic pressure? It's no more than the volume that is coming outside due to high pressure in the capillary. So it makes sense that the main etiological factor that increases hydrostatic pressure is hypertension. The higher the pressure, the higher the hydrostatic pressure, the higher the volume that goes to the outside, the more edema, right? Now, but in addition to that, not only hypertension, but also disease processes that are consequences of hypertension. So any disease process that you can imagine that comes from heart, from valvulopathies to left ventricular hypertrophy to CHF, aneurysms, atherosclerosis, decreasing the lumen of the capillary, anything that increases blood pressure and complications of hypertension will produce high hydrostatic pressure, producing edema. Now, since we need to have a good amount of protein to be able to bring it back in, okay, one of the major proteins that we have is albumin, okay? The other one is globulin. So it makes sense that if you have increased proteins, which decreased proteins, think about the first most common cause, which is malnutrition, right? Elderly populations are very high risk because either economic, they cannot afford, have good source of protein intake, I have seen them in restaurants sharing one soup. And I tell my husband, we're gonna be like that. Yeah, because the retirement is not enough, right? So anything that leads to malnutrition will lead to decrease on cardiac pressure. But in addition to that, any disease process that excretes large amounts of proteins, and that could include nephrotic syndrome, cirrhosis of the liver, okay? And any disease process that we'll study here, which is glomerulonephropathies that patients can have, proteinuria, okay?
Doesn't glucose control that also?
Okay? So that's what I'm referring to. So all the factors that affects glomerular filtration rate, of course, the arterial tone, and we'll study, might not be today, but renal artery stenosis, which is not coming to board examination, unfortunately, but it's a disease process that has to be known because a lot of practitioners miss it, okay? Because unfortunately, it's a diagnosis of exclusion. So the higher the tone of the arteries, of course, the higher the pressure, and that could affect glomerular filtration rate. If you have one kidney that is stenotic, you have another kidney to compensate by the other regulation that I just explained. But if both kidneys are affected, imagine that, what could happen, okay? And of course, what else could affect glomerular filtration rate? Any medications or toxic substances that you will study in 669 that could affect renal clearance. Okay, so how do we measure kidney function? Well, we could measure through sensitive but non-specific diagnostic tests and also more specific ones, right? BUN, remember that BUN is no more than blood urea nitrogen. And because it's not only taking into account the urea, which is the main wasting byproduct of the kidney, it does take into account B for blood and N for nitrogen wasting byproduct, which come from the muscle mass, right? So blood, if you have a patient with anemia, since blood is volume, decreased volume could have increased BUN. So think about blood for the BUN, that the lower the volume, the higher the BUN, right? Because remember, the pre-renal arterial and glomerular filtration rate is affected by volume, right? So dehydration, anemia, patients that have hemorrhage, anything that affects blood, and that could include cardiovascular conditions that affects cardiac output, could elevate BUN. And if you have the contrary, which is the volume overload state, patients would have low BUN, okay? So that's the reason why BUN is not accurate. And also take into account nitrogen wasting byproducts. Again, if you have a patient cachectic, or if you have a patient that has decreased muscle mass, or if you have hypogammaglobulinemia, patients that have immunocompromised disorders, or patients that have, for example, again, cachexia or any type of malnutrition, marasmus and Kwashiorkor, etc., could affect BUN. So that's the reason why BUN, and this is a question, still a question, but you ask, we have that question over and over. BUN is not a specific factor for renal function. It's just sensitive. Okay, of course it guides you a lot, but creatinine clearance is the best. Okay? So, and that helps us, of course, evaluate if the patient has the pre-renal, intrarenal, or renal blockers. That we're going to go in a second, but you might recall that from pathophysiology. Okay? Remember, creatinine clearance is the most reliable diagnostic test. And I'm not going to make you calculate creatinine clearance, but there's a formula for that. Okay? So, creatinine. Remember that creatinine, as I told you, creatinine is a byproduct of the muscle mass. Okay? It's the protein metabolism. So, anything that affects your protein levels, like malnutrition, could also affect the creatinine. That's the reason why I told you, elderly patients, sometimes they have renal failure, And we know that by GFR, or we know that by creatinine clearance in a 24-hour urine collection, or by the formula itself, but the creatinine could be normal, just because they have a decreased muscle mass, okay? So, in addition to that, anything that affects the GFR, glomerular filtration rate, remember that glomerular filtration rate depends on the volume that's coming from the pre-renal arteriole, right? So if you have hypovolemia, that will create hypoxia, and tissue ischemia or hypoxia at the level of the nephron will affect your glomerular filtration rate or creatinine clearance. So any disease process that gives you hypoxia would give you elevation of creatinine and GFR as well, okay? Now, I want you to look here, as I explained already, patients, what are the limitations of GFR if you have decreased muscle mass, like you're cachectic, just because you have cancer, or you have liver problems, or you have any type of malnutrition. You can have also decreased creatinine, and it's not a reliable value. Remember, creatinine clearance, don't click creatinine only. Creatinine clearance, which is the best, okay? So, in addition to that, anything that affects plasma levels, you have hemorrhages, etc., or if a patient has medications that could affect the GFR, as soon as you discontinue those medications, the GFR increases, and they're not like standard or specific factors that will tell you this patient has renal failure. It's just a risk factor that is present when you urinate. Then we present to you the, it's called Cockcroft-Gault equation, okay? We used to put it in exams to calculate it, but we don't do it anymore. Why? Because it's coming already in the laboratory test, okay? But I want you to look that age is the factor, and why? Because the older you get, the less muscle mass, right? And also, your ideal body weight is a reliable factor in the formula because, again, muscle mass, okay? And the amount of volume that you do have. And sex, okay?
So you said hypoxia increase the creatinine and increase the GFR or decrease the GFR? Increase the
What do you do in the case that you have a cancer
Doesn't really matter.
where you have to do the sex in the phone?
No, you have to do the real sex.
The genetic sex.
The genetic sex.
Okay.
sex. Because the volume of distribution doesn't change if you cut it off. Okay.
On
Okay.
distribution.
Going back again to pathophysiology, remember that the kidney controls osmolarity and how. We studied an electrolyte which is highly important for the control of osmolarity. Remember that osmolarity is no more than the ratio proportion between the volume and the solutes, right? So who controls osmolarity? Sodium. It's the main electrolyte that controls osmolarity, right? And in addition to that, there are hormones that controls osmolarity. And those are your ADH and your aldosterone, okay? So, there's a discrepancy about the values of osmolarity, but the most agreeable values is not up to 320, okay? It's 280 to 300. In some books you have 280 to 296. So I will tell you to memorize 280 up to 300, okay? Because even though the PowerPoint is from your book though, says up to 320, the guideline only accepts up to 296. So when you have it higher than 300, you already have a high osmolarity, okay? So it raised at 320, and for me, 300, okay? So now, remember that, how is osmolarity controlled? Well, first, if you have any changes in sodium, I know you should know this already, but let's go back a little bit. Remember, this is the ECF. This is the ICF. And think always, 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 when I talk about intracellular fluid, it's the cell. And when I say the cell, it's your brain. Because unfortunately, the one that is mostly affected, even though every single cell is affected, the patients would have, the first initial symptoms tend to be neurological manifestations, okay? Okay? When you draw blood from a patient, you draw blood from the ECF, not from the ICF, okay? So whenever I refer to the values of sodium, I refer to the values in the ECF. I don't have to say it. It's common sense, okay? So if I tell you hypernatremia, it's in the ECF. And if I tell you hyponatremia, it's low sodium in the ECF, okay? Yeah, some students ask that question, okay? So that's why I'm refreshing. If I tell you now, and I put it in big so you will know that it's hypernatremia, remember that it's 135 to 145, okay? Remember you have what's called diffusion and osmosis, right? So, the sodium controls diffusion, right? Diffusion of solutes. And remember that diffusion or osmosis, which is water, goes from the higher concentration to a lower concentration. So if you have hypernatremia, since we have to compensate, sodium goes from the ECF to the ICF, from the higher concentration into the lower concentration, right? Since I have hypernatremia here, that means that if osmolarity is no more than the ratio proportion between volume and solutes, if I have high solutes, that means that I have low volume. Yes or no?
Yes.
So high sodium, therefore low volume, right? So the solutes will go from a higher concentration to a lower concentration by diffusion, and the water by osmosis go from a higher concentration to a lower concentration. Because if the volume is low here, it makes sense that it's high here, right? So that means that the cell will shrink, and the patients anyways will have, yeah, on top of dehydration, the patient will have neurological manifestations. And the backwards applies for hyponatremia, okay? They're gonna have the pleasure to memorize the entire algorithm in 669. Or we can do it here to anticipate. Okay, in addition to that, remember that osmolarity is also controlled by the aldosterone, right? Whenever we have changes in sodium, that's perceived by aldosterone, which is the renal cortex, but it's also perceived that by the neurohypophysis, which releases vasopressin, which is ADH, right? And remember that aldosterone will reabsorb sodium and water and excrete potassium to balance it out, and ADH only water, right? And you went through that insipidus and all that. In addition to that, what affects sodium levels? Well, if you have a patient, if you remember the algorithm of hyponatremia, okay, what can affect sodium? Well, sodium could be affected. Let's talk about hypo first. It makes sense that you could have hyponatremia because you're losing sodium, right? Or you could have hyponatremia because you're retaining water. Yes or no? You either excrete sodium or you're diluting the sodium. So how can you excrete sodium? Well, you could excrete sodium by the only ways you can do that. Kidney, right? So if you are in diuretic, which is the most common cause, you can have hyponatremia, right? But in addition to that, how else can you lose sodium? Sweating, vomiting, right? So those are the GI and the renal causes, which are the most common, right? But in addition to that, what do we say about the renal function? Not only controls volume, but controls electrolytes. So if you have any type of renal failure, you will start losing sodium as well. In the first stages, in acute renal failure, because in end-stage renal failure, what happens is that you start retaining volume, okay? And then what you're doing is diluting it, right? Okay. So this is like in general. Then you have to know the specific. In addition to that, if we go to hypernatremia, remember that hypernatremia can also be present by losing lots of volume or retaining lots of sodium, right? So how can you retain a lot of sodium? Well, you can retain a lot of sodium because you're giving me sodium. Because you have, for example, a patient with subarachnoid hemorrhage or intracranial hemorrhage that has cerebral edema, and you're giving me 3%. Or you're giving me a hypertonic solution such as bicarbonate, for example, or you're giving me mannitol that is super concentrated, even though it's no sodium, increases osmolarity, right? And it makes sense as well that you can have high sodium by losing plenty amount of water. And the most common cause there is diabetes insipidus. Okay? Then we'll go to this. You're going to remember neuro again in renal because it's very highly interrelated. Okay? So the first auto-regulatory mechanism when the patient is dehydrated or when the patients have alterations in sodium is to go to the refrigerator and drink water because the thirst mechanism, it gets activated, right? What happens if you are immobile, in traction, or your thirst perception is lost because you're an elderly patient? That can happen. And the majority and the most common cause of renal failure in elderly population and in any older population is dehydration. So that's the reason why when you don't know the patient, or you don't have a prior history or family member to ask for, or you don't see an AV fistula, or the patient doesn't have a catheter, that you know that it's an end-stage renal disease, that doesn't mean that the end-stage renal patients cannot have dehydration, right? But the most common cause of an acute renal disease is dehydration or to proven otherwise. Okay? And that's the reason why you give volume to the patient. Now, the fun starts. And is the major classification of renal failure, which is pre-renal, intrarenal, and post-renal. So, if I tell you that pre-renal is before the kidney, what comes before the kidney? It's an artery, right? And an artery that is supplied, which the renal artery is a branch of the aorta, is supplied by the aorta, right? So imagine if I have a coarctation of the aorta, or if I have aortic stenosis, or if I have any major atherosclerotic plaque, or I have a major aneurysm that is impeding blood flow properly through the aorta. But the aorta is coming from the left ventricle, right? So if you have the ventricular hypertrophy, that could affect the blood flow coming through the left ventricle, which is the cardiac output. Any disease process that decreases cardiac output will give you low volume, right? And besides that, what contributes to cardiac output is the preload. So if you have a decreased preload because you have dehydration, bleeding, anemias, anything that decreases volume, diarrhea, vomiting, major sweatings, right? Or even, believe it or not, we're going to study mechanical ventilation, which is what is called insensible losses. You lose volume when you're on the ventilator, okay? And also, disease process that can affect volume indirectly because they have a major volume shift, such as sepsis. Even though you may read in the book that sepsis is in pre-renal and sepsis is also in intrarenal, but nobody will be able to ask you that one in an exam. Because why sepsis could be pre-renal? Because there is a major fluid shift into the interstitium, right? Producing hypovolemia and therefore acute renal failure. And why is it renal? Well, it's renal due to the amount of nephrotoxins that are released due to the major inflammatory cascade activated. So that's why it could be both. And I don't want you to get confused because I'm not gonna ask you that one, but it's true that it could be both. Now, it's more commonly pre-renal, because what actually happened, what do you do for a patient that's coming with sepsis? Fluid resuscitation, because that's the major cause, okay? Hypovolemia. So as you could see, if you're dehydrated, if you're bleeding, why heart failure? Most likely, not the diastolic heart failure, but the systolic heart failure, right? Any patient in shock, any shock, hypovolemic shock, cardiogenic, people used to say, or the book says, no, because it has an increased pulmonary artery pressure, that actually in reality the patient's preload is elevated instead of decreased, but we don't have enough cardiac output if you don't have cardiogenic shock, okay? The same as, if you remember septic shock, again, the amount of prostacyclin and all the inflammatory mediators producing capillary permeability, the patients would have a lot of interstitial edema and therefore hypovolemia. If you think about obstructive shock, which we're gonna go in 669 as well again, even though it was a pathway. Obstructive shock, if you have a patient with pulmonary embolism, if you have a pulmonary
You draw
embolism,
better than Morton, though. Morton doesn't draw.
well, if you have a pulmonary embolism, what happens is that there is an increase pressure at the level of the pulmonary vasculature, and that produces a pressure regurgitant to the left, to the right ventricle, producing what's called cor pulmonale, which is an acute right ventricular dilation. And remember that if you have an increased pressure here, what happens is that, if you recall the hemodynamic, okay, normally the blood comes from the inferior vena cava and superior vena cava, and this tricuspid valve open mediated by pressure.
So you push the
So
pressure.
once you have increased pressure in the atrium, the tricuspid valves open to be able to fill the right ventricle. But in this case, the pressure is backwards. So the amount of volume that comes from the superior and inferior vena cava cannot go into the right ventricle, therefore it backs up. And the patients will have right ventricular failure and all the signs and symptoms of it. But that impedes not only preload, but what doesn't come in, doesn't go out, right?
We get fluid overload, I want that, right?
Yeah. So that's a cause of obstructive shock. Another cause of obstructive shock, if you have a tension pneumothorax, right? If you have a tension pneumothorax,
Or cardiac tamponade.
or cardiac tamponade. So if you have a tension pneumothorax, remember that here you have your heart, right? Yes?
Yes.
No. So if your lung is completely collapsed, puts pressure in the mediastinum, right? Displacing the heart into the left lung. And the more you push, the less expansion, relaxation diastole, the less amount of preload, the less amount of cardiac output. The same thing happens in cardiac tamponade. If you have a film of volume surrounding the heart cannot expand properly, therefore the amount of volume that goes in is low, therefore the cardiac output is also low. Okay? So those are also examples of pre-renal failure. Why liver disease?
Because you can have portal hypertension.
One of the hypertension. Another cause of decreased preload or decreased volume in liver failure is what I explained to you. Decrease on public pressure, therefore the fluid stays in the outside, producing edema, and that amount of fluid exacerbated in the interstitium doesn't go into the right atrium or ventricle, right? And therefore the cardiac output is also compromised. Okay? Renal. So you understand pre-renal? It's really easy. Now, I don't know if you recall that I explained in pathophysiology that even though it is assumed that an obvious cause of intrarenal renal failure will be nephrotoxins or any medication that affects glomerular filtration rate or creatinine clearance, right? If you're on aminoglycosides or if you have a patient with or glomerulonephritis, so anything that affects the nephron directly, any vasculitis, you would see musculoskeletal, because it's highly important not only for renal but also for pulmonary, lupus nephritis, right? You have a patient with hypertension that gives you renal vascular disease. You have a patient with diabetes that gives you also nephrosclerosis, right? So any glomerulonephritis, any vasculitis, any autoimmune condition, any medication that affects the glomerular filtration rate and creatinine clearance directly, makes sense that it will be the common cause of intrarenal renal failure, but you are wrong. Because the most common cause of intrarenal renal failure is no more than a prolonged hypoperfusion. So normally a patient comes to you with an acute renal disease, and again, the most common cause of an acute renal failure is pre-renal until proven otherwise. That's why you don't ask, and you have to give fluids to any patient that is an acute renal failure. Do you understand? Now, you're expecting the next day or the next 48 hours that your creatinine improves after you give fluids. But you don't know exactly how many days this patient has been in hypovolemia, right? So the longer you wait, or the longer you misdiagnose this disease, and you don't treat properly with fluids, the longer the glomeruli will be in tissue hypoxia, and it will lead to necrosis. And that's the reason why it was widely accepted that the most common cause of acute renal failure is a prolonged pre-renal disease. Do you understand? So once you see that the patient, in 48 hours, the creatinine doesn't improve, you might have to assume first, this is a disease process that is called acute tubular necrosis, which acute tubular necrosis is no more than necrosis of the tissue of the nephron after ischemia. So the same as the heart, that angina is ischemia and infarction is necrosis, well, pre-renal is ischemia and acute tubular necrosis is necrosis, right? So that's the reason why acute tubular necrosis is the most common cause of intrarenal renal failure. And how do you know that? Well, we have sediments that can prove that. Renal ultrasounds, to rule out, for example, that I'm in the presence of a chronic kidney disease instead of an acute renal problem, right? You're gonna go through, exactly, you can do biopsy, but it's rarely done, right? You could also do Doppler arteriography or ultrasonography on the kidney. You would understand that in renal artery stenosis. So there are many, many causes that can produce intrarenal renal failure. You could do a 24-hour creatinine clearance and look at the protein levels, etc. You will see how, for example, in lupus, we will do the specific antibodies. So basically, once you treat the patient with volume and the patient doesn't improve, you're going to start doing a series of diagnostic tests to rule out other diseases. Unless, of course, you see the patient coming through the ER already with the AV fistula or the catheter, right? You know already that that's chronic. Even though, again, you could take a lot of liters out in dialysis and put the patient into acute. It has happened, okay? Any question? So, we're gonna go through all this in detail next week, but glomerulonephritis is one of the second most common cause of intrarenal renal failure, but that doesn't mean that you're gonna just forget about medications that could be risk factors and try to discontinue them, right? So always please go through the list of medications. I don't know how many times, even though it's not my expertise because I'm pulmonary, but I do ICU as well. How many patients already have bypassed ER and have come to us, to the ICU, and they are on ibuprofen. Or they are on ACE inhibitors when they have acute renal failure, and that's the first thing you have to do, discontinue them. And you have to discontinue them, why? If a patient has an acute renal failure, pre-renal, you're suspecting that, if you give me an angiotensin converting inhibitor, which is ACE inhibitors or ARB, what are you doing? You're blocking autoregulation. That doesn't mean that the patient, once it's stable, is not going to be discharged with the same medication, but at least by the time the patient has dehydration, you have to stop it to allow the kidney to autoregulate. The same as if you have an inhibitor of prostaglandin, ibuprofen, Advil, Aleve, all that, you have to hold it. And many elderly patients come to you like that, okay? Besides, of course, chemotherapies, antibiotics that also can influence that, okay? Now, what else could happen to the patient? Well, patients can have glomerulonephritis. There are many causes of glomerulonephritis that I'm going to discuss in detail next week. That basically what happens is that they produce highly inflammatory response at the level of the nephron. And if you remember in patho, the nephron is very selective for micros, tiny molecules to bypass. It's like a filter. So if you take like a strain in your kitchen, the major particles don't pass through, right? Unless you strain, right? And the straining thing is diuretic, okay? Or if the filter is damaged. If it has a hole, of course, the macromolecules will bypass. So once the glomeruli is affected in intrarenal renal failure, and you have tiny holes, the proteins is the macromolecule, and it will start to filter. The same as the red blood cells, the same as the glucose, but the glucose has other mechanisms as well, as based on transport saturation. Okay?
So then, if that's the case, you have to give albumin, for example, to.
Well, the best thing is to try to look for the underlying condition, because there are many. We're going to talk about that next week, which is IgA nephropathy, head oscillate purpura, patients that have a streptococci, group A, pharyngitis in the past. So you have to try to look for the underlying lupus, etc.
But how can you fix that? The open.
The hole,
One is because.
you have to treat the underlying condition, and if the patient has increased amount of protein loss, yes, the only way to replace it is by giving albumin.
So eventually you'll lose it again.
Yeah.
Right. So then how do you?
That's why
It's
chronic.
It's and the
Right.
renal disease.
Controlling of mainline disease, patients will deplete less protein and less, starch type. Okay, so the only difference between the only normal cast, to make you aware, even though we're going to go deeper next week in glomerulonephritis, the only major cast that you eliminate in your urine is called epithelial cells. So it's from the epithelium. They're clear, they're not muddy brown cast, and it's not red blood cells, you don't lose proteins, etc., right? So for example, any inflammatory response will lose granular cast, which is mostly from tissue necrosis, and it will lose proteins, but never more than 3 grams per day. okay? When you lose more than 3 grams per day of protein, it's called nephrotic syndrome, okay? So the triad, even though we're gonna go deeper next week, the triad for nephrotic syndrome is proteinuria more than 3 grams per day. Patients would have, of course, because of low oncotic pressure, edema. And because of the edema, which is part of the same second, hypertension. Hypovolemia, hypertension, right? Yes or no? And the vicious cycle continues. And another one is once you start leaking proteins, which is a macromolecule, due to the same inflammatory response, you start leaking blood. So patients will have hematuria, proteinuria more than 2 grams, and edema associated with hypertension. Okay? Now, why lipids in the urine? It's very easy, even though it might not come to your mind right now. But going back to the past, what do you eat? Crab? You eat glucose? You eat proteins? And you eat lipids, right? Yes or no? So, remember that, doesn't have to do with any of that, and I'm not going to go back to ask you this. Remember that I talk more than what's necessary. Remember that when you eat, this is your main source of energy for any cell, right? So part is used for the metabolism, and another part is used to store in the liver, right? In the form of glycogen. Yes or no? Going fast. So, from proteins, you decompose into amino acids, and from lipids to glycerol, right? And fatty acids. So far, I haven't answered you the question. Now, if a patient, even though it has normal amount of glucose, the patient is losing a major factor of the metabolism. And if you remember, when you deplete the body of any factors of the Krebs cycle, when you deplete proteins, no. When you deplete protein, you only have glucose or lipids to be able to nourish the cell, right? Now, when you don't have enough protein because you're losing it, even though the glucose part is not affected and the process continues in glucogenesis, okay, or glucogenolysis, which is by glycogen, the body starts to grab on the lipid and starts to decompose lipids, thinking that it doesn't have enough factors for the energy, right, for the cell. So when you start breaking down lipids,
That's acid, right?
no, is an acid. So not only you get ketones, right, but not only you would see, yes, ketones in the urine, but since the lipids has to go through the kidney to be reabsorbed and used again back in the cellular metabolism, the kidney has a hole. I mean, the nephron. So it starts depleting lipids in the urine, producing lipiduria. So not only the patient has hyperlipidemia, but has hyperlipiduria, which is lipid in the urine. So fatty urine. Like you see the many cells of fat in the urine.
Wow. Never heard. Yeah, this is syndrome that have that, right?
Nephrotic syndrome.
Nephrotic syndrome.
Okay? So we're going to go in details next week about this, but I just want you to see what are the causes of glomerulonephritis. It could come from just an infectious process, patients having group A, beta strep, pharyngitis in the past. Remember that produces valvulopathies, produces synovitis, patients have carditis, okay, and nephritis as well. That's what we have to avoid and treat strep infections appropriately. But in addition to that, patients with HIV, they can have glomerulonephritis. patients with endocarditis, hepatitis. Lupus, even though it is on the membranous proliferative, is also an autoimmune condition that can give you a progressive glomerulonephritis as well. As you could see, is in both because it's an autoimmune condition. But we're gonna go through each of them. You have IgA nephropathy, you have vasculitis, which produces a good pasture. This is highly prevalent in pulmonary conditions, the same as Wegener's. And this is a vasculitis as well, an Ashwin improvement. We're gonna explain all that next week. So any vasculitis, any autoimmune condition, even hematological conditions that we studied last semester can induce glomerulonephritis and renal artery stenosis as well.
Well, I guess if you have like a like anything that produces like DIC or stuff like that can put you in that.
What about
Blocking the
sickle
nerve-
cell
It's
disease?
blocking the nerve.
Anything that blocks the capillaries of the kidney can produce not only renal artery stenosis, but can decrease the tissue perfusion of the kidney and lead to this. Okay? So we're gonna start combining all that this semester. So, as I told you, and I want you to memorize this, the most common cause of intrarenal renal failure is prolonged tissue hyperperfusion, which the disease process is called acute tubular necrosis. Now, do you think you're gonna go back after this? Do you go back after myocardial infarction? That particular tissue, reversible? It is not. That particular area that is necrotized is not. It is not. Now, you can have one kidney affected only, and not both. That's the hope. Okay? And as you could see, what's the leading cause of that? Hypotension. And hypotension, it could be due to medications, but it could be due to dehydration, to any cause of hypovolemia that we already mentioned. And as you could see, sepsis is also there. Could be related to hypotension due to prolonged hyperperfusion in pre-renal, or could be due to the amount of inflammatory mediators that are released in sepsis. Okay? But again, what about medications? Look, aminoglycosides, chemotherapies, medications that we also take for rheumatoid arthritis, amphotericin, IV contrast, highly prevalent. Okay? So if you have a patient going through cardiac cath or angioplasties, angiographies, any radioactive contrast can induce intrarenal renal failure. Okay? That's why we have to prepare the patient to prevent that. Rhabdomyolysis. Why rhabdomyolysis? Regular muscle breakdown produces myoglobin. And that pigment is highly toxic for the kidney as well. Okay? Now, what I want you to remember that when you have an acute tubular necrosis, which is the most common cause of intrarenal renal failure, your cast, meaning that the sediment that is present in the urine, in a urine analysis, is highly specific for that disease. It's called muddy brown cast. Okay? And that is really important to remember. Okay? Now, other conditions that can do that, look at multiple myeloma. Besides all the diseases that I have explained. Okay? And again, we're going to go through each of them next week. These are muddy brown cast, of course, seen in a microscope. And is again, pathognomonic of acute tubular necrosis.
And you would see it like when you do a 24-hour urine collection, or you would see it
No, just
normally
a
in a
peripheral
normal-
smear in a regular urine. Okay? Now, other diseases that can induce intrarenal renal failure, again, all the autoimmune conditions that we're going to study in musculoskeletal, because even though you might think musculoskeletal is only osteoarthritis and rheumatoid arthritis, no, it's more than that. So from sarcoidosis to lupus to Sjogren disease to scleroderma to any type of vasculitis. What about hypercalcemia? And I want you to kind of like erase that from intrarenal renal failure? Because it could be in both, in intrarenal and in postrenal. Why? In intrarenal, because if the kidney is unable to reabsorb calcium properly because the patient has, for example, hyperparathyroidism, that calcium will accumulate in the nephron and will damage the nephron, producing damage of filtration, right? The renal filtration rate will be damaged, therefore it's intrarenal. But you know that one of the most common causes of hypercalcemia or consequences of hypercalcemia is renal calculi or nephrolithiasis. And nephrolithiasis is the cause of postrenal. Okay? So any obstruction of the uterus, urethra, bladder will be post. Right? Pre, what goes into the kidney before. Intra, inside the kidney, in the parenchyma. And post is your renal pelvis, is your ureter, is your urethra, and your bladder, and your prostate in the man. Okay? What about polycystic kidney disease? Not only you release high amounts of testosterone, that's the reason why the patient has hirsutism and irregular menstruations and ovulatory cycles, but you also have hypercalcemia as well. And that could be one of the reasons, but again, just erase the hypercalcemia portion. Now the easiest one, actually the two easiest one is pre-renal and post-renal. Post-renal is no more than anything that obstructs the outflow of urine. Once the urine is formed, coming out from the pelvis, and when I say pelvis, the renal pelvis, the ureter, the bladder, the urethra, and the prostate. But not only inside, but what about you have a tumor in the abdominal cavity that is compressing on the ureter, or for example, a big pregnancy, ectopic in this case, that can produce compression. I have seen it in the ureter. So any tumor that compresses the ureter, any urethral vesical urethral reflux, if you have the bladder again, imagine that this is your bladder, right, kind of conic, all right, and you have oh my God, you have a hypotonic bladder, right, or overflow incontinency, and or you have, for example, cystocele, and you have a lot of residual volume in the bladder, and that amount of volume starts to accumulate and regurgitates back or backflow into the ureter. You may say, well, it's only up to a piece, but as the condition worsens, you can have dilated ureter, but in addition to that, remember that in the kidney, you have something that's called a pelvis, right? So once the renal pelvis is dilated, that is called hydronephrosis. So any disease process that produces a dilation by backflow of urine into the pelvis produces what's called hydronephrosis, and you can see it easily in a renal ultrasound, okay? Have you seen nephrologists always doing a renal ultrasound? It gives you a lot of value. One, you could see any obstruction. You could see if the pelvis or the calyces are dilated by hydronephrosis. You could also see the size of the kidney. The kidney should be more than 7 centimeters. Any condition that can decrease the size of the kidneys, producing atrophia, that will at least tell them that that kidney is not going to be functioning anymore. This is a chronic kidney disease. Do you understand? It's nothing acute going on. It's chronic.
In that case, what would you do if it has hydro?
Well, if it's produced by an obstruction, you have to reduce the obstruction.
Yeah, treat the cause.
Yes. If it's a calculi, you have to reduce either nephrostomy or nephrostomy, or actually going in and
Removing the
take it out.
stone, stenting.
or produce a stent. So think about all the diseases that can produce post-renal. What about if you have a calculi in the uterus? Nephrolithiasis can give you obstructive. What else? A tumor compressing, either from the outside or in the actual uterus or the bladder.
What about BPH?
What about BPH? So in the guys having benign prostatic hypertrophy can produce as well post-renal. Okay? So now we're going to go again quickly through each of them. Or again, or prostate cancer as well. Okay? So again, what is the most common cause of acute renal failure? It's an abrupt hypovolemia. So you think about any disease process that can decrease the volume. Now, if you have acute renal failure, the same as chronic, but of course this is going to be long-term and it's going to be more managed or compensated by the patient because it's for many years. What's the function of the kidney? Volume regulation, right? So the patient in acute renal failure, even if they are hypovolemic, they won't be able to control volume properly. The first mechanism is to do autoregulatory response, right? The catecholamines, renin-angiotensin, aldosterone system. But if they can't manage that, eventually, if they go into acute renal process, they cannot manage volume and they will start having edema. Kidney is one of the participants, or the main organ that participates in acid balance, the same with the lung, right? So if you have a patient with acute renal failure, remember that sodium is going to be affected. Most likely they have hyponatremia. They tend to have hypocalcemia, hyperphosphatemia. They also tend to have hyperchloremia and hyperkalemia, giving metabolic acidosis. So metabolic acidosis is the most common, okay? And of course, there is a major cascade of events as the disease process advances into chronic renal failure. We're going to go there in a second. Okay? So again and again, the most common cause of acute renal failure is pre-renal. That's the reason why, don't tell me in an exam, oh, but you never said pre-renal. Why fluid? Because the majority of the patients that come to a hospital with an elevation of creatinine is pre-renal until proven otherwise. Okay? And if you don't have a person to give you the history, even more. If you don't see any signs of end-stage renal disease and hemodialysis, even more. You give fluid. You're going to put the patient in pulmonary edema because you didn't know. It doesn't matter, honestly. There's no liability on that because the guidelines and research and experience tell us that 70% or more of the patients that come to the hospital in acute renal failure, they have lack of volume. Okay? Now, after that, of course, prolonged hyperperfusion will give you acute renal necrosis, and we need to avoid that. Because why would the patients have a high mortality? Because once you have acute renal necrosis, your chances to go into end-stage renal disease and hemodialysis and all the complications of CKD, you can name it, right? You have increased risk of CDA, myocardial infarction, having anemias, having having hyperphosphatemias, hypocalcemias, hyperkalemias, and major metabolic acidosis. You can't control volume, you have hypertension, etc. Okay?
So Professor, pre-renal will be reversible.
Oh, yes.
Intrarenal is not reversible.
Okay? You can improve or avoid advances of the disease by treating the underlying condition if you're able to recognize it. You understand? So, what are the risk factors that can give you acute renal failure in general? Of course, the older you are, because the more medications, the more comorbidities you have, the more medications you're on. In addition to that, as I told you, muscle mass, malnutrition, perception of thirst is affected. That could also affect volume status. If you have a pre-existing renal disease, of course, when you go into hypovolemia, you can have more damage. Patients with hypertension, diabetes, or any autoimmune condition that will lead to renal failure, that's a major risk factor. And as I previously stated, anything that affects the cardiac output will go through a vicious cycle of renal failure. Okay? Now, there are many phases of renal failure. You might think that every patient in acute renal failure is oliguric or anuric. Not really. Okay? What happens is that what you see in clinical practice is the most common phase, right? If the patient, of course, is the most common cause of renal failure is pre-renal. If you have hypovolemia, the amount of volume that goes into the renal artery is decreased, and therefore GFR is decreased, and therefore the amount of urine will be decreased, right? But that could last, if you don't treat it on time, that could last maybe 15 days, right? So the patients will come, as we stated, with high BUN. Why? Because a volume blood component, right? Patient cannot eliminate properly the urea, which is a wasting byproduct of the kidney, and they will start accumulating, right? They will have elevated creatinine, the potassium. Patients will have hyperkalemia because remember the kidney is in charge of that. The amount of urine is very small, so it's very scarce. So basically has oliguria. They have a concentrated urine. So the urine osmolarity is increased, right? Specific gravity is increased. And the patient's osmolarity could actually varies. I mean, sometimes at the beginning of the stage, they tend to have a high osmolarity because they're dehydrated, and as the disease advances, then of course the hypervolemia will produce the more osmolarity, okay? Now, believe it or not, once the first week and a half or two passes, practitioners might think, oh, the patient's getting better because the patient is urinating, okay? Because the problem is that now, since the kidney is unable to concentrate urine properly and reabsorb all the solutes and water, it starts to eliminate plenty amount of hypotonic urine. And you see the patient urinating and you think, oh, my, it's getting better. Or the family members that have no medical knowledge of it, the patient's urinating, but the creatinine is getting worse. That's called polyuric phase or diuretic phase, okay? And the recovery phase, which again, if you catch it on time, the recovery phase could be a good prognosis once you start the patient on IV fluids and you see the creatinine getting lower and lower back to baseline. But recovery phase also might be interpreted in chronic kidney disease as going back to baseline, but there's no actual recovery of renal function. Do you understand? Like if you were already a CKD patient or an end-stage renal disease patient and you have a super acute decompensation due to hypovolemia, I can bring you back to baseline and that will be recovered for you, but not completely recover of renal function. Okay? And here is what I have told you. Remember that we tend to have a lot of misconception about anuria. Anuria doesn't mean zero urine. Anuria means that you are excreting less than 50 mLs of urine in 24 hours. So you might have a little bit in the bag, but if it's less than 50, you're anemic, okay? You don't have to have like 0. And in that case, the only way you can excrete wasting byproducts of the metabolism is through dialysis. You could do a temporary dialysis or, depending on the renal damage, long term, okay? Again, the most common cause is pre-renal, followed by acute tubular necrosis, which acute tubular necrosis is the most common cause of intrarenal. Even though it's a little disorganized, but it's just based on the most common causes, okay? Remember that patients that have, and again, it's explained here, usually due to ATN or renal, which is a prolonged tissue hyperperfusion, okay? Now, remember that glomerulonephritis, acute interstitial nephritis, and we're going to talk next week about atherosclerosis producing vasculitis or renal stenosis, or cause of intrarenal. And remember, post-renal is obstructive. Think about anything obstructing after the kidney.
So when you have like for the oliguris, we and the barcode says hypervolemia. It's hyper or hypo?
As I said, in the oliguric phase, what you see most commonly present in the patient is hypovolemia. Why? Because it makes sense. It might, exactly, it's not in the vascular space. Patient can be edematous. For example, patients, if they have cirrhosis of the liver, they would have pre-renal renal failure, but that amount of volume is outside, it's not in the vascular space. As the disease progresses, then what happens is that patients will be hypovolemic, right? Because the kidney is in charge of controlling volume, and they can't, okay? Now we're also going to be talking about the use of diuretics. I don't know if you have seen nephrologists giving diuretics on patients that have acute renal failure. Sometimes when they already see some type of acute tubular necrosis that the patient is not responding properly to IV fluids, they give a challenge to diuretics to see if the kidney responds. We're going to talk about that next week. Okay? So what do you have to ask the patient? Not only for pre-renal renal failure, but would it be important that if the patient has cancer and is on chemotherapy, so a patient with cancer on chemotherapy, that will be a cause most likely of intrarenal, right? Any recent infection that the patient might be at risk for sepsis, right? A UTI, any pancreatitis, anything pre-renal. Huh? Better strat. Remember that I'm not going to ask you because it's impossible, not even in extra examination of boards, to ask you sepsis, which classification is it. But remember, sepsis most commonly would give you a major fluid leakage, and therefore is most commonly pre-renal. Have you seen any blood in your urine? Because hematuria could be an indication of, for example, nephrolithiasis, that you're bypassing a stone, right? But hematuria could be also because you have a hematological condition that you can't coagulate properly, right? Or what about your platelets? Or what about if you are expelling red blood cells in the urine because you already have a nephron damage, nephrotic syndrome or glomerulonephritis, right? The same as flank pain. Having a flank pain could be an indication of renal stenosis, nephrolithiasis, mass, okay, etc. So vomiting, diarrhea, major sweatings, anything that might lead you to think about hypovolemic state. Okay. The same as family history. We want to know, for example, if a patient is in any NSAID use. Remember that NSAID by itself is a medication, right? That can produce intrarenal. But if the patient is on NSAIDs or ACE inhibitors because the patient has hypertension, okay, you must discontinue those in pre-renal renal failure because the patient would not be able to regulate, okay? That's the most important part that I want you to remember. But what about if the patient tells you, I suffer from hypertension, the patient doesn't comply to hypertensive medication? We already went through hypertension is one of the leading causes of nephropathies, and that will be renal failure. So going through the physical examination, wouldn't you be concerned if the patient now comes with a blood pressure of 200 or 120? That not only will give you decreased hyperperfusion, but if the patient is being in a long time with uncontrolled hypertension, that leads to renal nephropathies, right? And intrarenal renal failure. Now, why would the patient be confused? For example, remember that urea is a nephrotoxic substance, but also neurotoxic, so patients tend to be with neuropathies. Remember, as I told you, hypercalcemia, right? Can induce intrarenal renal failure. The patients are not hypercalcemic. Let me emphasize that. When you have renal failure, it's hypocalcemia, hyperphosphatemia, but hypercalcemia is a cause of renal failure, not a complication, okay? All right. So any malignancy, as I said, if you see dry mucous membrane, might lead you to think, oh, this patient is dehydrated, is hypovolemia, right? Having ascites, for example, due to either liver cirrhosis or any major malnutrition or having nephrotic syndrome, or ascites because the patient has right-sided heart failure, that would be an indication of renal as well. Now, in liver, we're going to talk about portal hypertension, and we're going to discuss how, for example, patients with an elevation of pressure in the portal system not only will deviate pressure to the lower pressure systems, which is your esophageal veins and the intestine and the anus, but in addition to that, if you have increased pressure at the level of the liver, the preload will be affected, and if the preload is affected, the cardiac output is affected, and the renal perfusion is affected. So when the patients have liver failure, okay, or liver cirrhosis that increases pressure at the level of the portal system, that impedes blood flow in the inferior vena cava to go into the right atrium, and therefore cardiac output is compromised. And the patients would have renal failure due to liver conditions. Okay, and you will see the same applies for pulmonary conditions. There's something that's called hepatopulmonary syndrome. Okay, we're gonna go slowly. All right. So, and again, you see a patient with edema. You see a patient that's having proteinuria in the urinalysis. You see the patient that is having hypertension. Makes you think the triad of nephrotic syndrome, right? And we're going to go through all the autoimmune conditions so you will be able to recognize. So far, I'm not going to ask you autoimmune conditions because we haven't gone through that yet. But I need you to be aware of the causes, okay? So, in addition to that, we can determine exactly, even though the most common way to do it in clinical practice is by history. Because if I now tell you that I went to Spain, which is not true. I mean, I went to Spain, but it's not true that I was vomiting. Imagine that I had an abdominal pain, and I ate a lot there, which is true, and then I had food poisoning, and I started vomiting. That's my history. What would you think? Dehydration, right? That's hypovolemia, that's prerenal. So look at the history of the patient. That will most likely determine the type of acute renal failure, and you would treat accordingly. But in addition to that, with what we have, what's called fractional excretion of sodium. It's very common sense. Don't look at the equation, because I'm not going to make you calculate it, but it makes sense. What do you think the kidney will do if you're dehydrated? Will you excrete sodium to get more water up? Because remember, sodium brings water with it, right? So if you start excreting sodium through the urine when you're dehydrated, you're going to be more dehydrated. So it makes sense that the mechanism of compensation for the kidney when you're dehydrated is to hold on the sodium, right? So you would have more sodium in your plasma to bring more water in plasma, but you would not excrete a large amount of sodium in the urine, right? Even if your urine is concentrated because you're dehydrated, the amount of sodium in the urine is not large. Do you understand? Remember, your nephron is not damaged yet, all right? So, the value that is mostly agreeable is that the fraction excretion of sodium when you have pre-renal due to any cardiac output affected or dehydration, any disease process that we have already discussed as pre-renal, the amount of sodium in the urine will be less than 1%. Okay? And it makes sense that if you have either, if it's the most common cause, which is acute tubular necrosis, or any disease process that leads to intra-renal renal failure, which you already have nephron damage and a hole in your filter, you're going to start excreting large amount of sodium, right? Because the kidney is unable to compensate that anymore, right? So the amount of sodium in the urine will be large, which is more than 2%. And that also applies for post-renal. And the problem with post-renal is very variable when you read the books. If it's, for example, a temporary condition that hasn't affected the renal pelvis or the parenchyma by reflux, you shouldn't. But it's mostly agreeable, but the value is exactly the same as intrarenal. So you want to understand this better. You need to know this. Now, before we go through this table, which is highly easy to remember, you will see how easy it is. Look at the last sentence that I have here. Would it be accurate? What did I tell you at the beginning? That the glomeruli is the filter in your kitchen that only bypasses macromolecules unless it has a hole or you're straining, right? If you have a filter and you're pouring orange juice with pulp, the pulp is going to stay, right? Unless you do this. If you squeeze it, it's going to come out, right? That squeezing effect is produced by diuretics. So that's the reason why when the patients are on diuretics, it's not a reliable exam to do fractional excretion of sodium, to be able to determine if it's intrarenal, postrenal, or prerenal. Because if you are dehydrated because you were in diuretics, well, it makes sense that I will stop the diuretics and I will give you fluids, right? Why would I go through this if I know already that your fractional excretion of sodium will be high? So that's the reason why we don't do it as much in clinical practice, but unfortunately you're tested on it everywhere. So, now, another thing is BUN and creatinine ratio. What is BUN and creatinine ratio? It's no more than, even though there's a formula, I want you to know it like this. Imagine that you have a patient coming in with, remember that your BUN value is 10 to 20, right? And your normal creatinine is less than
12.
sometimes. Well, depends. Sometimes in some hospitals it's up to 1.5. Put up to 1.5. Okay? So what about if you now come to me and you come in with a BUN of 26, okay? And the creatinine is 1.9. Okay? To be able to know this, you need to know the baseline of the patient.
Right.
Because what about, how do I know the ratio proportion from before? If I don't know you, the only thing that I can do is give you fluids and see if these values decrease. And if these values decrease, well, you have renal. Easy. right? But this is based on, unfortunately, you could do outpatient clinical practice too, based on specialties, right? So if you're gonna be working with nephrologists, you don't only go to the hospital, you can be in the office too. So if you have a patient that is known to you, that you know the baseline creatinine, and even in the hospital, the patient has had prior admissions, and you're able to go back and see the patient's baseline BUN and creatinine, you're able to determine that ratio. Imagine that the patient's BUN and creatinine baseline is 20 and 0.12. Normal, right? Now the patient comes back to you, or comes to the hospital where the patient had a prior admission, that if you go back, now the BUN is 36, and the creatinine is 1.9. As you could see here, if you have, this is BUN, this is creatinine. If you have a bump up, like increasing amount, of more than 10, you are pre-renal. So you look at the prior creatinine, imagine that it's normal, and now from 20, it went to 16 more. And from 0.12, it went to more than 1% ratio. Do you understand? So you could determine by this that the patient has a pre-renal. Do you understand? Yes or no?
Yes.
But what about if you now had a patient with 36.9 baseline, and when the patient comes back, you see the numbers and you're like, oh my God, this patient is an acute renal failure. Go back to the prior baseline that you had in the prior admission, and now you see that the patient has a 38, and let's imagine that it's 2. It's chronic. They give you a higher than 10-to-1 ratio.
But you have to know baseline.
Yes, unfortunately.
According to the patient.
According to the patient. The only way to know, for example, if this is chronic or acute based on your treatment is treatment response. If the patient now is 36 and 1.9, and again, I give fluid, the patient has to go down. But if it's coming up, not pre-renal.
So you still get fluids?
You could give it up to 48 hours, but after that, what's gonna happen? If it's chronic renal failure, the patient
Okay,
can
so-
manage, well, you have to stop.
Okay, so you're not gonna do that for that patient. You're just gonna be like, okay, renal ultrasound.
No, you have to do all that, yes.
Estoy todo confundido.
Okay.
Fluids or no?
You do.
You have to give fluids, yes.
To
But
see if it works.
but the patient has no response, of course you're gonna have to start
Oh, of course.
searching for
You do
causes
the
of
fluids,
intravenous
yeah,
renal
yeah.
failure.
It's only like, you only give fluid the first 3 hours to see how it is.
Exactly.
To see if it goes up or down.
You
Okay,
know
goes
that
up,
they
yeah,
have
hold
chronic
on.
renal failure and have an AV fistula and are getting dialyzed. I just don't-
If you have no prior medical history, how would I know that this patient has CKD? If I don't have a prior BUN, a prior creatinine, and there's no family history, there's no fistula, there's no history saying that, well, the nephrologist told my family member, because I've heard that too, that they need dialysis, but he has refused. That's a pertinent history, okay? Now, what else?
So you
What
give
about-
fluids, but maybe like 500 or 1,000? No, not so much.
At the beginning, you have no idea.
Yeah, 'cause you don't know.
But what about if
You
you
don't know. Now, she's asking me how much fluid, which is part of the fluid electrolyte replacement in 669. The first amount of fluid that you give to any patient is 30 ml
Per kilogram.
That will be your box. And then after that, there's a formula, which is the easiest to remember, is your weight plus 4.
The weight plus 4 kilograms.
For what?
40, I'm sorry, 40. Plus 40, 40,
That's
40.
That's the maintenance.
There are many formulas, which I will teach you, but the easiest to know, if I'm 70 plus 40, 110. But nobody's gonna give 110, so you get 100 as well. Right? That's maintenance. But any bolus that you will give to a patient is 30 mL per kilo. One time. Okay? So what about urine sodium? What did I tell you about urine sodium? If you are dehydrated, common sense is that your kidney is going to retain sodium in plasma, and it's not going to excrete in the urine, right? So the urine sodium will be less than 20, which is your normal value, right? And once you have renal damage or post-renal renal failure, again, remember, this is not referring to the temporary condition. This is mostly referring to already having hydronephrosis by reflux. It will be the same as intrarenal. Specific gravity. In the urine, if you are dehydrated, will your urine be concentrated? So your specific gravity, which again is very similar to osmolarity, is the ratio proportion of volume and solutes. Sedimenting will be high. Compared to that, you cannot be able to concentrate urine because your kidney is already damaged in intrarenal and postrenal. So your urine will be diluted. And even if you see almost no urine, or the patient is having less than 50 mL in the end-stage renal disease, if you analyze that urine, even though you see it super dark, it's mostly present on lack of volume, but there's no solutes. Urine sediment. Remember that your normal is epithelial, which is transparent, it's kind of like crystalline, so that's called hyaline, which is completely normal. Okay? Now, once you have an inflammatory condition like glomerulonephritis, it will be mostly granular. And remember, I want you to remember muddy brown cast in acute tubular necrosis, okay? And this could be completely normal, the same as pre-renal, but I'm going to concentrate on that one. And the major factors that I want you to remember on this table is the urine creatinine ratio, your urine sodium, which is the same as fraction of excretion of sodium, right? Less than 1, remember that you do not waste sodium when you're dehydrated, so it will be less than 1. And more than 2, which is could be 3, don't fix the number. So less than 1 in pre-renal, more than 1 in intrarenal and post-renal, okay? Any question? So here you have, what can you do if you give fluid to the patient and the patient doesn't improve? Well, let's start looking for the causes that we already labeled for intrarenal renal failure or post-renal. So how will you know that the patient has already a chronic kidney disease? Well, let's do an ultrasound. The ultrasound is going to give you the size. If you have an atrophic kidney, you either were born with that, or you have lack of a kidney, maybe you have agenesis of the kidney, no kidney, or you could see also the pelvis and the calluses to see if they're dilated, right? Those are causes of post-renal as well. In some renal ultrasounds, if the calculi is radiopaque, you could see the calculi. Okay, there are many, many things that you can see in the renal ultrasound. Okay, so
Would it be
hydronephrosis.
possible that the kidney get shrink and start, the size of the kidney starts shrinking?
If it shrinks, because it already has a
Which is a bad.
So, is it safe to say that the patient comes in with suspecting a renal calculi, it's better to do a renal ultrasound to be able to see?
Even though the CT scan of the abdomen is the gold standard examination for nephrolithiasis,
Yeah.
you can catch it with the renal ultrasound or KUB.
Can you be?
Yes. If it's radiopaque, yes. Okay? So what else can you see in the urinalysis? Well, if you see hematuria, remember that hematuria could be just a simple UTI could be just a simple calculi passing through the ureter, damaging the ureter, therefore the patient has hematuria, but it could be major complications such as glomerulonephritis or nephrotic syndrome, right? You can also see in the urinalysis that is tinged, but it's not actual red blood cells, could be myoglobin, and if the patient has been bedbound or unconscious for a long time, or strenuous exercise, or any major risk factors that lead to rhabdomyolysis, or statins, for example, that might let you think about rhabdomyolysis, and you can see that. But in addition to that, you could also see sediments are highly suspicious of autoimmune conditions that are going to go in musculoskeletal, okay? Now, in the renal ultrasound, you could also see, if you add Doppler to it, you could see the renal arteries, the flow, and the peak flow of the renal arteries that will make you think about the possibility of renal artery stenosis, okay? So protein in the urine, remember that if you have less than 3 grams, it's glomerulonephritis. If you have more than 3 grams, it's nephrotic syndrome, okay? And might let you think about all the conditions that, again, we're gonna go one by one next week. Again, it's just for you to remember that the most common cast that is present in acute tubular necrosis, which is the first leading cause of intrarenal renal failure, is muddy brown cast, okay? Then other diseases that can give you, for example, if you have nephrotic syndrome, remember that I told you that only you expel big amounts of protein, more than 3 grams, but you have hyperlipidemia, hyperlipiduria, so your cast not only will be glomerular in nature, but you will also have fat. Okay? Fatty cast. Lipids. Actually lipids. Okay? Now, there are many other exams that you can do that would be specific in renal artery stenosis. For example, you could do an MRA of the kidney. You could also do CTAs if you're suspecting renal artery stenosis, but remember that all this contrast can also affect the renal function even more. The last resource is your renal biopsy. Rarely done,
Really? Because I see the numbers drop just like all the time.
but it's highly risk.
Yeah. Do they?
But it's like,
I have a ton of patients.
like
with
you
renal
have no
biopsy.
idea what's going on to the patient, you have gone through everything, and then, but it's not like commonly, you know, the first phase.
No.
Okay? And mostly, yeah, when you do renal biopsy is that you have gone through every single diagnostic test, you have ruled out all the conditions, you have no idea, or you're preparing the patient for transplant, okay? So how do you treat? Well, it makes sense that pre-renal renal failure, even though all of them you treat the underlying condition, pre-renal, the fluids to the patient. If it's related to decreased cardiac output because you have systolic heart failure, remember, isotopes as well, okay? So treat the underlying cause. If it's related to hypertensive emergency or urgency that is decreasing the tissue blood flow to the kidney, treat that as well. How do you treat hypertensive emergencies?
Oh, the emergency, you're gonna give labetalol or esmolol IV.
Okay, labetalol or esmolol, those are your beta blockers. You could also give calcium channel blockers, which is your Cardine IV. What else can you give? You could give nitroglycerin or nitroprussate, even though we don't do it as much because of the handling and the cyanide toxicity, but it's part of the guideline. And how do you treat urgencies? Even though, again, what you see the most for urgencies or emergencies, you see the same treatment in clinical practice. But unfortunately, you have to go by guideline, okay? Now, if the patient, for example, has a urethral stone that is already dilating the pelvis, you're gonna put the patient into chronic renal failure and end-stage renal disease if you don't take out the pressure. So you either do nephrostomy or nephrolithotomy, so basically going in and taking out the stone nephrolithotomy, it's called like that. Or you have to deviate pressure, the patient is critically ill. You can take this patient into the surgical room and do an renal procedure, so you could deviate the ureter to the outside, to at
And they
least
come
reach the
back to
pressure.
Yeah, you create a nephrostomy.
Is that reversible?
Yeah, you have them.
The same as we have done at the bedside patients with cholecystitis due to stone and
They do T2.
abscess in the gallbladder. We have deviated the collecting duct on the outside. Cholecystitis. If the patient is critically ill, they cannot go to the surgical room. Okay? Now, we're gonna talk about how you treat renal crisis in autoimmune conditions, so we're gonna do that little by little, otherwise you get confused. Now, when do you give diuretics? Will you give diuretics to pre-renal renal failure?
No.
No. Now, if the patient has a glomerular filtration rate, that we're gonna go in detail in chronic renal disease, when you have different GFRs, if the patient has less than 15 glomerular filtration rate, diuretics don't work. You need to have an appropriate population to be able to treat with diuretics. So you need to have more than 30 GFR for the diuretics to work. Otherwise, the only way to excrete metabolic wasting and volume is through dialysis. Okay? So,
When they're, since you're talking about diuretics, when they're like in renal failure, like they're in the chronic, isn't it better to use Bumex instead of Lasix?
if you, yeah, Bumex or anticlinic acid works better to recruit glomeruli, and so the patient will start urinating. If you give Lasix, you have to give a high dosage. So that's the reason why you see nephrologists giving 60 milligrams, 80 milligrams, and you're like, what? Because Lasix will not respond once the patient is no more than 30 GFR. Okay, so Bumex and anticlinic acid would be better. And again, dialysis, and we're gonna talk about dialysis in chronic renal failure, and of course, the last resource will be renal transplant. Okay? So this is the last slide, but I have a complete PowerPoint for CKD, so we'll leave it here.
Professor, I have a question.
Yes. Isn't it? Is that the last slide?
No.
But I have a complete PowerPoint for CKD.
So if you wanna see the urinary cast, so how do you order it? Cause I've never seen.
It's reported in the urinalysis.
Yeah, I've seen it, yeah.
They see it like, you see it like with the name?
I think they only
Very
report it if it's there. It's not like how you always say
Right.
WC 0. I think it's only if they see cast or they add it in.
Oh.
That's what I think. 'Cause I've seen it with
Cause I see red blood cells, but I never see the muddy brown.
No, but
The
it's,
patient doesn't have,
So if they have it, it's when they write it. If
Yeah.
they don't have it, they don't have to write it in the urinalysis. So there we go. Oh, I never seen the muddy brown. In the urinalysis,